Lateral aspect elbow joint. To examine the lateral aspect elbow joint, the patient is seated on the chair, the elbow joint is flexed, and the forearm is pressed in the neutral position. This is like a praying position. The examination of the lateral aspect elbow starts from the supracondylar ridge and progress distally to the brachioradialis, extensor carpi radialis longus, extensor carpi radialis brevis, extensor distal communis, extensor carpi alaris, and the lateral collateral ligament. Brachioradialis. By positioning the probe parallel to the forearm at the proximal supracondylar ridge, the brachioradialis muscle, radial nerve, and brachialis muscle can be identified. Extensor carpi radialis longus. At the distal supracondylar ridge, the extensor carpi radialis longus can be identified below the brachioradialis muscle, which is attached to the supracondylar ridge of the humerus with a short tendon of about 0.5 to 1 centimeter. Extensor carpi radialis brevis. By moving the probe further downward and placing the proximal part of the probe on the lateral epicondyle and the distal part on the radial head, the extensor carpi radialis brevis muscle can be observed. The extensor carpi radialis brevis is located between the extensor carpi radialis longus and the lateral epicondyle. When observing the area between the elbow lateral epicondyle and the lateral head using ultrasound, the superficial part of the hypoechoic is tendinous component, and the deep part is composed with the lateral collateral ligament. The tendon and the lateral collateral ligament, which make up 50% of the humeral attachment. Again, the superficial layer of the tendon part is the extensor distal communis tendon, and the deep layer is the extensor carpi radialis brevis tendon. Because these two tendons are joined approximately 2 to 3 centimeters distal to the lateral epicondyle, ultrasound images cannot be differentiated between the two tendons in terms of location. Lateral ulnar-collateral ligament. The lateral ulnar-collateral ligament can be observed by lowering the proximal end of the probe slightly directly below the lateral epicondyle and rotating the distal end of the probe toward the ulna on the posterior of the forearm. Damage to the lateral ulnar-collateral ligament can cause posterolateral rotatory instability and may require surgery, so it must be examined with caution. The saxipum recess. The saxipum recess is a space observed in the radial neck area. If fluid retention is observed in the saxipum recess, joint effusion should be suspected. Lateral epicondylopathy. The most common cause of pain in the lateral side of the elbow is related to the extensor carpi radialis brevis muscle. When evaluating the origin of the extensor carpi radialis brevis, the entire origin, including the lateral epicondyle, lateral collateral ligament, annular ligament, and the intermuscular septum must be observed. I recommend the dynamic examination that examine the lateral epicondyle area using ultrasound while resisting extension of the affected wrist joint. This is because if there is a partial tear in the tendon attachment to the elbow joint, applying the resistance extension and the radial deviation to the wrist joint can help a diagnosis because change in the size of the ruptured area can be observed. The lateral ligament complex consists of lateral collateral ligament and annular ligament and the lateral ulnar-collateral ligament. If a varus stress test is performed in the elbow joint, the damage to the lateral ligament complex can be better observed. However, caution is required to strong. A varus stress test may cause further damage to the damaged structure.